Today, I presented at MOASC three data sets. The first data set was in metastatic castrate-sensitive prostate cancer, so-called Arash trial, and we presented the data with ADT plus docetaxel plus minus darolutamide. These patients continue to get the triplet or doublet until the disease progression or unacceptable toxicity. And then we showed that there was overall survival benefit in subset of patients with de novo metastatic disease or patients who had recurrent disease. We discussed another data set, so-called PEACE-1, which used a similar approach with ADT plus docetaxel plus minus abiraterone and prednisone as their novel hormonal agent. And again, they showed overall survival, and the data in high volume setting was rather impressive. At the end, we discussed the necessity of docetaxel to be added to ADT plus novel hormonal therapy, whether it's necessary to have chemotherapy or not, and we discussed possibility of adding, possibility of performing another trial, maybe with ADT plus novel hormonal therapy, plus minus docetaxel to show the benefit of docetaxel. And I mean, I mentioned it's probably a very difficult trial to accrue to give chemotherapy or not to patients, and also getting the funding for that and get the trial going with a drug which is already generic, maybe through the cooperative groups possible, but generally a difficult trial to do. The second data set that we talked about was EV301, which used enfortumab vedotin in neoadjuvant setting for patients who were not eligible for cisplatin-based chemotherapy in neoadjuvant setting. And we showed the data with PT0 and PT downstage both, and the efficacy on this drug is a small patient number in that trial, which generally showed benefit. We discussed issues with that small subset on that trial, so-called cohort H, and possibility of having a larger trial, which is ongoing, and showing benefit in T3, T4, higher stages of bladder cancer. And in the end, I showed a list of trials looking at the same patient population who are not eligible for cisplatin neoadjuvant chemotherapy, cisplatin-based neoadjuvant chemotherapy, and maybe benefiting from the checkpoint inhibitors plus minus ADC in different settings, and there are multiple trials ongoing right now. And the last data set was using pembrolizumab in adjuvant setting for patients with intermediate high, or status post-mastectomy with RCC, clear cell RCC. And we discussed the updated data set with 6 more month additional follow-up, which were consistent with benefit for disease-free survival rate. And at the end, we're waiting for another couple trials to be presented soon, hopefully at ESMO. There was a press release that showed that announced that the ipilimumab nivolumab versus placebo in a similar patient population was done by BMS, and that trial did not meet the endpoint of disease-free survival. There's a similar trial with atezolizumab, which was, again, the same patient population with high-risk disease or intermediate high-risk disease. And we'll wait for those data to become available and hopefully, put all these 3 trials to make suggestion and treatment recommendation for our patients. So at the conclusion, I want to say that we all have to continue to accrue to trials to get answers to these unanswered questions for our patients. And continuing to support trials is a very important thing for all of us. Just want to mention that at the end of my talk.